So saliva is your friend. This is not my phrase. It is either from Washington Post or New York Times. About 25 years ago, we discovered saliva has anti-HIV activities. So this is a headline of a newspaper. Saliva is your friend. Okay, indeed, saliva is your friend. But for dentists, none of you are dentists. For dentists, saliva is really is evil. We try to isolate. We try to clean out saliva before we do any dental procedures. So for dentists, saliva, in the dental chair is evil. But for the patient, saliva is a very important component in oral cavity. It is a major. I think it's loss of the battery. Anyway, this is the major host defense mechanisms. Okay, if you don't have saliva, your tooth is going to rotten, get dental caries or gum diseases. Also, they protect your soft tissue. Okay, the saliva contains a lot of antimicrobial proteins, growth factor. Saliva also called fountain of youth because they have so many growth factors there. So we always say the phrase that you lick your wound, right? Why you lick your wound? The reason is saliva has a lot of antimicrobial proteins and the growth factor there. So saliva provides a basic lubrication function. If you don't have saliva, your oral mucosa is going to stick with your teeth, so you cannot speak, you cannot swallow, you cannot move your tongue or anything at all. Again, you hear a lot of people, especially older people, complain about the tasteless. So sometimes you don't have a taste. It's not necessary a taste bud changes. It's sometimes just you don't have saliva as a solvent to deliver the taste to your taste bud. So older people commonly suffer with mouth dryness. If they don't have appropriate saliva in their mouth, they always complain they don't have, the taste is different. That's another reason. So so salivary gland dysfunction means they don't produce enough saliva, or saliva composition changes. They may cause a lot of problems. Mouth dryness itself is a terrible experience. It's a suicidal phenomenon to some patients. And certainly you got a lot of dental disease. You severely compromise your quality of life. Sometimes you can get life-threatening diseases because of a lack of saliva protection. But today I'm not talking about the saliva, how important it is. So during the aging, saliva affect your salivary gland tissue a little bit, but most people, very difficult to demonstrate, but it seems aging is more effective into the submandibular gland than the parotid gland. I tell you what is the submandibular gland. I parotid later. But the saliva also contains a lot of biomarkers. So in the past several years, the federal government, the state government, tried to push using saliva as alternative body fluid diagnostics fluid, because when you collect saliva, it's not like you collect serum or other body fluid. You have less there's no invasive procedure there. You just spit it out. We always say we study spit. So the medical professionals need a less training. If you want to stick somebody, you have to train them to go to the van or go to the. But for saliva collection, it's less. Less. You need some training, but it's less training, less stressful situation, easy to correct. okay, in the non-conventional medical center. You can go to the mall, collect saliva, you can go to anywhere to collect saliva. It's relatively allowed, so you have less privacy concern, right? You can grab somebody, if you want urine, it's not so easy. They may cheat you in some way. Recently, I have been called out to have a urine test for my drug survey, so they have two people, stand next to you to watch you pee. Anyway, this is a less privacy concern. The patient also, the subject also felt much more relaxed, less stressful, because there's no needle stick, nothing. But also saliva has few problems we have to deal with. First, the biomarker in saliva totally depends on the salivary flow rate. Okay, that may changes with flow rate. It depends on the molecule. Not necessarily that change with flow rate, but depends on the molecule. So most of them change with the flow rate. Also, saliva is limited amount. Okay, especially when you're nervous, your secretion decrease right away, and so there's a limited amount. Not like blood. You can have to draw a lot of blood, but even blood has a limited amount. Once I studied as HIV, when HIV come out, I'm the first dentist to study HIV. So everybody asked for. At the same time, I was at NIH. So everybody got excited. Everybody wants blood of HIV. If you understand, HIV cells is a blood disease. They deplete all the T cells. So everybody said, give me 5 ml. The patient comes in, everybody say, I want 5 ml there, 5 ml there. One day the physician say, oh, stop. Everybody asked for 5 ml. The patient blood is going to disappear. Everything is going to drown out. So, but I have no problem to collect saliva from this patient. Okay, that's another thing. So, but saliva compared to blood, you have a limited amount. Also, because of this is still in a very frontier kind of research, biomarkers have not well been described or studied. So government really pushed these things. So at late last century, early this century, NIH, NIDCR put out 2 major grant for people to apply. One is a salivary proteomic category, or salivary secretory component. The other one is develop technology for saliva oral fluid-based diagnosis. I'm fortunate that I can, I participate in one of these studies. So I'm going to present some of the data to you today. Then not at the same time, then lately NIH and the Texas Center tried to improve oral cancer diagnosis and treatment. I will tell you why that's a big issue. Anyway, so oral cancer is a big problem. Also, it's elderly people, older people's problem. So lately, we see a lot of oral cancer patients in our CLC clinics. So oral cancer is aging-related disease. So I'm fortunate. I also being involved in this stuff. So I'll show you a little bit this. So just give to you a little bit of what is salivary glands. In human, we have 3 major salivary glands. We have a parotid gland, submandibular gland, sublingual gland, and we have numerous minor salivary glands surrounding your oral cavity. So you have plenty of salivary glands. Aging seems more affect on submandibular gland than parotid gland. So if you look at the salivary gland under the microscope, you can think about grapes. Okay, you have all the grapes as the arsenic cells, they secrete out secretion. Then they go through the ductal system, which is the stalks of the grapes. So salivary gland, just like the grapes, they squeeze out the juicy liquid through the ductal system. And the salivary gland is only gland stimulate the flow by sympathetic nerve and parasympathetic nerve. Okay. If you know our body system, very often there is parasympathetic nerve doing something, sympathetic nerve doing something, like your heartbeat. Parasympathetic nerve slow down your heartbeat, the sympathetic nerve speed up your heartbeat. But in saliva, both, that's the only organ in your body, both your stimulate parasympathetic nerve and the sympathetic nerve can induce salivary flow rate. Okay. Parasympathetic nerve stimulate saliva is more fluid, more watery kind of saliva. Sympathetic nerve stimulate the saliva is more mucus, more thick, more protein kind of saliva. So they produce different kinds of saliva. So I think that's an interesting fact, to know. So each day we'll produce about 750 ml of saliva you swallow. So you didn't notice. If you look at each day, you probably can produce some. You cylinder, you produce so much of saliva. You swallow. Most of the saliva, when you are not eating, most of saliva from some mandibular gland. Okay. When you are eating, most of your saliva comes from parotid gland. That's a physiological reason, because some mandibular gland produce more protein, like what we call the mucin, like saliva. So they can moisten your mouth, cover your mouth for a long time. But when you're eating, you need a more watery kind of saliva. So parotid gland is going to secrete out more to let you swallow the food. So salivary gland not only produce saliva, they also have other mechanisms to let the serum composition go into the saliva. Okay, this is a mechanism. I don't want to bore you here. I just let you know there's at least 4 different mechanisms. Serum composition can go through salivary gland into your mouth, okay, into your oral cavity. Certainly, how this component goes through the salivary, go through the salivary gland depends on the molecule's property. Okay, so you can see from this slide. So clinically, when we say saliva, there's we call the whole saliva, means you spit out everything from your mouth. Okay. So basically you spit out in the mouth. Actually, when you spit out the fluid out of your mouth, it's not just the saliva. They have a lot of compositions there. Okay. A lot of serum composition. You have fluid come from respiratory tract. You have a fluid come from gastrointestinal tract. You have oral epithelial cells shed from your oral mucosa. And also you have microorganisms in your saliva. So it's a mixture, a lot of things there. So this is saliva we probably use for our diagnosis. Then you have a granular saliva. So-called granular saliva is a pure saliva. We can clinically use non-invasive method to collect saliva from individual glands, okay, not mixed with other things. So this is the way we can collect saliva. So we have other commercial product can collect oral fluid, not necessarily saliva. There's you can ask patient spit, you can rinse the oral cavity, then spit it out, or you have all these commercial product. Depends on your purpose to collect your saliva. So what are the potential biomarkers in saliva? electrolytes is one of them. Okay, saliva has electrolytes. The electrolytes modified by the salivary gland itself. So usually we look at electrolytes to sort of reflect the flow rate of the saliva, and also look at the integrity of the salivary gland. Okay. So then you have proteins. We're going to discuss how many proteins in saliva, and you have RNAs. Again, this is a good story. You know, if you handle RNAs, you know RNA is very fragile. Okay, we always say, I don't know whether it's true. People say your fingertips have a lot of RNAs. So you always wear gloves, use a special treated water to prepare your RNA. So there's one medical student come to a mentor, ask for, I want to study RNA in saliva. If you are salivary gland research, people are laughing at you because saliva has a lot of RNAs there, okay. But the mentor said, well, it's a dumb thinking, but dumb thoughts, but if you want to try, go ahead. So the student, this medical student did discover RNA in saliva, although not necessarily whole piece or intact RNA, but they have a lot of RNA pieces there. So this RNA can be used as a disease diagnostic biomarkers. So we always need a new. The lesson is we always need a new blood come to the field, since we are. We are already boxed in a very small area. We need somebody. Then the saliva, in the whole saliva, certainly you have a lot of DNAs because you have a bacteria there, you have a host cells there, so you can get a lot of DNAs from there. So in forensic medicine, people commonly use oral swab or saliva to do the DNA match or DNA printing. So saliva has all the potential biomarker there. In saliva, we have about 2,000, total about 2,000 proteins identified. There's a lot of unidentified peptide fragments there, but identified about 2,000. So about 1,200 from salivary gland, another 600 come from serum. So there's a very abundant of potential biomarkers there. So also we have about 3,000 messenger RNA sequence being identified in the saliva. Plus you have miRNA. miRNA is a small piece of RNA which regulate protein synthesis. So in saliva also have miRNA. So people try to use a signature of mRNA or miRNA try to do a disease diagnosis. So current existing, there's already have a lot of salivary assays there. So existing, the one thing is for the drug. Okay. One people ask me right now, everything legalized. The pot is legalized. All this, is there a way we can monitor them to police can put them? The product is already on the market. The police law enforcement people already use saliva as one of resource to check all these drug level. Also, you can check the smoke exposure, smoking exposure. Another thing is a psychologist always use saliva to test the cortisol or to test estrogen, testosterone, all these hormones to look at your stress level. So this kind of studies always, this kind of assays already exist. Also, right now there's a test for infectious disease. one of the examples is HIV. So this is an HIV quick test. Use the saliva. The whole procedure takes 20 minutes. Okay. Why is it important for HIV test take for 20 minutes? Because if you go to a sexually transmitted disease, people come in, you draw blood. If you you send to the central laboratory, you wait for a day or two. Patient will never come back. If they are HIV positive or HIV negative, the patient lost forever. Very good chance. Okay. But if you have this kind of saliva-based study, in 20 minutes you can tell. You just ask patient sit there. In 20 minutes you can tell whether the patient has a possibility of HIV infection or not. Then you can do the counseling right away. So that's the key for develop a salivary gland-based study, based equipment. So also you can use saliva to detect bacteria, virus, fungi, DNA, RNA, protein. This is all of that, in the or it already exists. Some of it already commercialized. Also we can use a microorganism recovery. You can culture the bacteria, virus, or fungus from your saliva or cavity. So this is a current existing technology. So potential use of saliva as diagnosis. People already try to study autoimmune diseases, use the saliva as a biomarker. The biomarker in saliva is a way to make a diagnosis, screening, or monitor autoimmune diseases. Another thing is cardiovascular diseases. There's a lot of markers, biomarkers in cardiovascular diseases. One of our studies to study acute myocardial infarction. Okay. Use the saliva as a diagnostic fluid. Also, you can use oral cavity, oral fluid to do cancer screening, because there's a cancer specific molecule can leak into saliva. So if this kind of yes or no situation, if you have specific cancer-related molecule in saliva, you can make a quick screening and diagnosis. So for develop saliva-based diagnostics, there's several things we have to put in our mind. Is must be a multiplexes. Before one disease, one biomarker, one disease, that era is past. Okay, it's very difficult to find one biomarker, one disease. You always need multiple biomarkers. Then you get an algorithm. Then you get a score. Then you can decide whether the patient has a disease or not. So the first thing you have to think about multiplex, simultaneous to make several screening, several molecule screening, not just one. You need to develop a machine that can screen in multiple analytes. Has to be very high sensitivity and specificity. You have to have the method very sensitive and very specific, and at least have a high quality control. At least have the same, as good as a central laboratory quality. That's a challenge. Okay. Because this is in the field to use this. Then you have a miniaturized, portable lab on the chip kind of design. So the goal is related to the goal is related. This machine can go anywhere. Can go to rural area. The major concepts, if you go to Africa, there's no medical resources, or patient is homebound. Very difficult to get into a medical facility, or in the rural area, you have a very few resources. You can bring this machine, self-powered, they emphasize ultimate self-powered point of care. Okay, you can bring this small machine to the field, either patients themselves or untrained, unskilled health professionals. Then take a sample, do the test in this machine. Then you can use the internet system right away, transmit to the doctor's office or somewhere. This concept, this practice already exists from my understanding, they already exist in Africa. A lot of HIV patients, they can just get a needle stick, the testing, right after testing, the result can even send to the Europe to make a diagnosis, to make treatment, make a recommendation of the treatment. So this is a telehealth kind of innovation. Okay. This is very, for aging, for geriatric, maybe it's important to know these technologies move around and can be used in the future to take care of patients. Sometimes you need a quick, another thing is you want a quick result, 20 minutes to get it. So the platform for the saliva oral fluid diagnosis, most common one is a lateral flow assays like HIV antibody assays. So this is one. Then there is a group in California, they developed narrow micro electrochemical multiplex molecular analysis. I will show you a picture of what that looks like and how it works. Then my research major involved the microbead based point of care nano bio technology or bio nano chip technology, depends on, they change their name all the time. So anyway, the last one is when I got involved. This is a narrow micro electro multiple molecular analysis. This is this is just two electrodes. Okay, so you give a current, you give a pulse current, then similar like you have antibody-antigen reaction. Once you have antibody-antigen reaction, you have a different current readout. So you can base on the current readout to get amount of the composition in the saliva or in any oral fluid. So this is and each electrodes can analyze one biomarker. So you can put hundreds. In theory, you can put hundreds, thousands of different electrodes there to simultaneously analyze 1 to 200 different composition in the saliva. I didn't involve in this. I just show you this technology is available. Basically, I'm involved in this bead-based multiplex analysis. Again, this is a huge national study, involved a lot of universities and clinical centers. So this is I'm very fortunate to be a part of this team. So this is our system. The system is very simple, just like you do a Western blot or you do the ELISA assay. Okay, basically you have microbeads like a sponge. It's a lot of small holes inside it. Then you have you have a capture antibody, just like you did ELISA. Then you have your analytes, your antigen. Then you have a second antibody, got fluorescence. But everything is miniaturized in the micro size, so that they put into a structure like a waffle. Each bead can do one assay. Okay, each bead is one assay. So each bead there, they can do a different assays. So in theory, you have an unlimited possibility. Use one small sample doing 100 assays, biomarker assays there. So So that's why NIH is so excited about this technology. So then they miniaturize this the structure. Okay. So the size of this miniaturized cassette, we call it cassette, is about do you guys know the floppy disk 3.3? Young people didn't know, but old people, folks like us know there's a floppy disk. This is about that size. So basically you put this into that circle, and then you insert to this machine, battery machine. There is an optical system that register whatever the result there, then the microcomputer can calculate the algorithm and decide whether the patient has this certain kind of disease or not. So this is the whole technology. Very easy, simple, easy. Just need a.
So Chih-Ko, you don't need any, how much saliva? You don't need to process the saliva before you add it?
Good question. Okay, we don't know. We don't know, but usually we just spin them. We just spin them. How that's another challenge. How do we process the saliva? How? Hopefully it's a point of care. You don't have to process. But there's a variety of ways you can process saliva. You can filter it, on the spot. It's not, you can build into the system. It's not, we haven't really detailed these kind of things yet. But when we usually use our saliva, we probably just, in the lab, we just spin it and store it away. So one project we want to study is acute myocardial infarction. It's about 800 people get a heart attack each year. About 60% recurrent, 25% is the first silent MI. The survival MI totally depends on the early diagnosis and early intervention. The EKG certainly is a good tool to make diagnosis of acute heart attack. But EKG only can detect 60 to 70% of real AMI. Okay. So the rest of the AMI, you need to use triage protein. So when people go to the hospital, if EKG looks normal, no problem, they still suspect they have a heart attack. So you go to the emergency department, you go to the hospital, they do more blood testing to see if they have biomarkers for the heart attack. Okay. So, but this is time consuming. When you come to this point, it's time consuming, may delay the treatment. Okay, the earlier the treatment, the better the success. So this is the biomarkers. Usually in the hospital doing this. So we use this technology. We use a serum biomarker as a start point. So turns out the cardiac disease is not so simple. Again, it's not one marker, one disease. Not only not one marker, one disease. Also, it depends on the stages of your disease. If you take blood sample right after the heart attack, then you take the blood sample of 24 hours, the biomarker changes. Okay, so it doesn't mean you have heart attack right now. 24 hours later, you test it. You may have a totally different profile of protein biomarkers there. So it's very stage dependent. So the first we want to test our concept, whether we can use this machine to do stage-dependent chips. We call chips this waffle beads device. So this picture just shows you the different stages of congestive heart failure, the progression of the congestive heart failure, and we can develop each dots here is one acid. Okay, so this green means they are positive. Okay, So you can develop different kind of chips, depends on your need. Okay, you can design your chips, or design this waffle, how do you organize your beads, okay, one by one. Or use an automated machine, you can develop these beads. So the result, just like this, the concept is proof. So one thing we want to do is, can we improve MI testing in the ambulance? That's one study we really go out to the community, work with the ambulance and collect samples from patients with a chest pain. So our laboratory process a lot of samples from patients with a chest pain. Okay. So what the ideal situation is that somebody comes in with chest pain, so they immediately did a 12-channel EKG, then look at it, at the same time you can take saliva sample, put it into this portable machine, can read out in 10 or 20 minutes. So when the patient arrives at the hospital emergency room, they already have all the diagnosis. Okay, that's the goal. So we have done some of this, haven't finished yet. All the samples collected. Totally depends on when our collaborators can analyze. So what we have done here, we can show you, this is normal people. They don't have a heart attack. This is people with heart attack, but it's a non-standing. So it's not EKG does not show the differences or apparent abnormal. This is a sign they call it, the EKG can make diagnosis. So you can see the panel. Based on this panel, each panels have a different biomarkers. So you can use this panel to make a diagnosis whether the patient has has a heart attack or not. Using a saliva. So here is the data to show you. This is you use a serum, you use a saliva. So when you use a serum, if you look at this is a area under the curve. That's one analysis to show how effective your method is. The closer to 1 is better. The best one is 9.999. The closer to 1 is better. So in 40-some patients we tested, okay, if you only use a EKG, they only can get a 0.8. But if you use a triage biomarkers plus EKG, you can get it into a 0.92. That's a big improvement from 0.1812. Area under the curve improved to 0.9 from 0.8. So that's serum. But if you use the saliva, same patient, you use saliva, you can see use a saliva biomarker and EKG can improve your diagnosis in the area under the curve 0.94. At least as good as using serum. So that is very, very encouraging data to us. So means you can use a saliva sample to make a diagnosis. So summary of this study is most important AMI serum biomarkers can be detected in saliva. That's one message. So this is our, I give you an example of what are these markers. Then, but unlike the serum sample, the 4 highest ratio in the median concentration of acute heart attack versus control ratio is different from serum. Okay, in serum you have troponin, all these other things, but in saliva there's a CRP, MMP9, L beta 1, and SCAN. So little bit different from a serum profile. Okay, when you come to the acute heart attack. So our conclusion is, saliva can be used as AMI, biomarker assay, and can be used, potentially can be used. All this conclusion I summarized in these 3 papers. This is based on 3 papers that summarize this result. Then next step, we want to see if we can use this technology for the oral cancer diagnosis. So oral cancer is a big problem. It's a relatively big problem. We have about 40,000 new cases, 7,600 deaths per year. There's no improvement of 5-year survival rate in the past 50 years. So one thing is we want to have early diagnosis, early treatment. So one thing we try to do is we try to combine with cytology with our nano chip assay. Okay. The thing is very easy. We change the bead-based reactor. We just put a membrane here. Same thing, same design. Okay. That's how you can look at it. So this is our 3 goals. Basically, we try to optimize the system and to get the algorithm to make a diagnosis. Then we try to implement this, validate this machine in the field. So this is how we did it. Basically you have a brush. You don't do the biopsy. Biopsy you need a knife or these kind of things. So you can use a brush. Okay, and this can do anywhere. I can do this here. No, I don't need a scalpel. I don't need anything to cut a piece of tissue. I just use that brush. I can get epithelial cells from your surface, from your oral cavity. So it almost can do anywhere. So like if you remember, this is the same cassette I showed you before. See, you have a microfluid system there. You have exactly. So basically, you change your waffle into a membrane. Okay. So you use a microfluidity. You change your the beads into a membrane. Then all the cell is going to stick on the membrane. The next step is the same thing. You label your cells with nuclear, with a cytoplasma, use a different dye. Then you can use different antibody to detect the biomarker you selected. So this is how it looked like after all the staining procedures. You see the normal cells there. This is a nuclear. This is a cytoplasma, the red color. The blue color is nuclear. But when you have cancer cells, you have enlarged nuclear, you have less cytoplasma. Then you can see this green dot is the EGF receptor. Okay, so that's the cancer cells. So based on the brush, you can try to detect these cells under this system. The rest of the picture show you the same thing. If you look at the benign or oral cancer. That's another thing is we try to use a morphological analysis using this system. So this is the way. We don't have time to go through, but just tell you how the computer dictate this nuclear size. They start from the brain. They can circle. The computer can make circle of the cells and the nuclear. Then they can highlight this abnormal nuclear. So if you look at the data, total data together, so you will see this is not perfect data. This is outliers. When you do 100-some patients, we have 1,000 patients right now. If you look at the patient with a benign lesion or with a cancer lesion, you can distinguish. Based on this, you can distinguish. They have a different, statistically different nuclear cytoplasma ratio. So far we have about 1,000 gender and age stratified subjects already sample collected in 6 or 7 -80 freezers linked to a central security monitor system. Okay. So we have the largest potential malignant lesion cytomics database. The bottom line is we want to make early detection on pre-malignant tissues. Okay, that's the key. You have to keep screening. You can catch them before they become a real cancer. So that's a goal. So this is the current achievement. So based on the morphological parameters such as nuclear cytoplasmic ratio and immunological biomarkers, we identified six of these biomarkers potential to use oral cancer diagnosis. So this is just another ROC curve analysis. You can see when you use the EGF receptor alone as a diagnosis tool, under the curve, curve area under the curve is 0.08. If you just use the morphological data, you improve a lot. But when you combine with nucleus and EGF, your area under the curve become 0.94, but the sensitivity of the detection become 97% instead of 61%. So this is our initial data shows this technology can be used to detect oral cancers. A future study, future challenge, you need to select a specific biomarkers. That's the key. We are struggling right now. We have a lot of data set there. What are the biosensitive, most accurate biomarkers? You need a lot of sample size and statistic analysis. You have to standardize saliva oral cell collection and storage conditions, just like Amrita just mentioned. We have optimization of the chemical reaction conditions. Certainly, develop quantitative algorithm so the machine can the test can be used for improvement of miniaturization of technology. And most important, one important thing is to get through FDA approval. That's one big hurdle. Another hurdle is we have to get a social and medical professional acceptance. Can the physician is willing to use saliva or trust with saliva or oral cells as diagnostic tool. That's a major, okay. Because if you want to commercialize this, you want to make profit. You want everybody using it. Okay, if you cannot not make profit, nobody's going to commercialize this. And so that's another hurdle. We have to educate our medical colleagues and educate our patient, educate in society for the salivary glands oral cell based the treatment or diagnosis screen. This is all my collaborator. This is the main reason we got all this grant, Dr. He was at the reason we get him is because he is at UTHSCSA. And he got all the funding, so everybody wants him to move to Rice University. So that's my talk. Any questions?
Chih-Ko, the question is the glandular saliva, is that sterile?
In theory, yes. Yeah. Depends on how you collect it. Yes, supposed to be sterile. Okay.
Does it make a difference in terms of the combination of kind of stimulated saliva versus just available saliva and how that will affect the sensitivity? to cancer cells?
That's the thing we try to figure out. We want to see if there's any kind of how is it, normalization molecule there. We can make some one possibility probably is hemoglobin level or albumin level. We don't know yet. This is the thing. The thing's happening, but we still have to work out a lot of details. Right? It's in our radar. We think about every day. How can we standardize the data or normalize the data? That's the key. For cancer, it's easy whether you have or not have, or you have a certain level or not. But for saliva, you have a little bit challenge there. But if it, like a cancer detection, if you have biomarkers, cancer, yes or no, it's easy. Like a drug reaction, whether you have a drug or no, you don't have a drug, or you have a drug at a certain level, that's easy. The problem is multiplex things. You have a few things increase, few things decrease. How do you get an algorithm to make it work? If you add this data, all variables there, people always criticize, you collect saliva, you never know their oral health conditions. That may affect the outcome too. So people, one paper, the author already put in all these consideration, how many tools you have, how much information you have in the oral cavity. All these things considered in can make a very good prediction of whether the patient has a heart attack. So the difficulty is we try to find, we try to collect this data, but finally we realize it's almost impossible for EMT people to make a quick diagnosis of all lesions. Yeah, we think about just like you said, all conditions. But we do, I think we do register how much saliva we put away in our study. So in the future we can make justification or statistical analysis. Okay.
All right, that's it. Thank you so much. I signed in for you, Van Val.